Our speaker today is Dr. Barry Raphael, who received his dental degree at University of Pennsylvania and his orthodontic specialty training at Fairleigh Dickinson. His practice in Clifton, New Jersey focuses on facial growth and the development of a healthy airway. He's a very highly sought after lecturer, but even more importantly, he's an old college classmate of mine from Bucknell University, and that's what's really important. But today, we're going to get his unique perspective on airway disorders in dentistry. Dr. Raphael, it is all yours. Take it away.
I just happen to have my Bucknell hat with me.
There you go.
Even though we've only made it into March Madness once, I feel like I have to wear this for you. All right, let's see. Let me share my screen. And tell me if you can see my title slide adequately.
We see your objectives.
Yeah. Okay. And Roger, boy, do I ever think that dentistry has a golden future. And I think at least a segment of it will have to do with what I'm talking about today. We're going to be talking just a brief review of what we're calling airway-centered disorders. It is a topic that is just emerging as important in dentistry, but the need for us to pay attention to it and the potential for having us work with the health and welfare of our population is so great that it is likely to be demanding our care well into the rest of the century. So I'm going to talk to you about airway dysfunction as opposed to sleep dysfunction. I know a lot of us dentists have gotten involved with sleep, but not necessarily with airway. We're going to learn how many of the disorders that we've been struggling with for many, many decades have a new meaning when seen in the context of airway. And I'm going to just do a brief review of some of the ways that you can open your eyes to these things because they are in your practice now. They have been sitting in front of you every day at the chair, but only waiting for you to be able to see them and to recognize them. And then hopefully at some point you'll start to address them. So this is my practice. Yes, Clifton is just 12 miles west of Manhattan. This has been a dream office. Yes, probably oversized as well. I built it to accommodate several associates, and I've only just invited them into the practice after well, it's nearly 40 years in the business and 15 with a new site, a new way of looking at orthodontics. Well, to make a long story short, it happened for me at about 27 years into my specialty practice. And I had always enjoyed orthodontics, and I always enjoyed sharing the results with my patients. But every orthodontist knows there are things that happen in practice in cases that compromise the kinds of results that we would want to get. And this picture is an example of one of them. That is an open bite when we're trying to get the teeth to settle down into place. And despite our best efforts, the tongue or the lips, the cheeks, any of the soft tissues, they seem to get in the way. And we can throw the kitchen sink at these problems only to realize that many times, not always, but many times, our efforts are not nearly as strong as the muscles are. So I had seen a few of these cases at the chair, which is the way things go, and sat down for lunch one day and picked up one of the industry rags, the Ortho Tribune, And there was an article there about the trainer system. This is one of the myofunctional orthodontic systems. It was written by a dual degree pedo orthodontist from Toronto now. And in this article, he made one point that frankly took me some time to really wrap my head around. And that was that soft tissue dysfunction is the cause of malocclusion. Well, we all know about tongue thrusting. We all know about thumb sucking and so forth. But to say that this is extant in a majority of cases was something that I really couldn't accept, and I suspect that many people still don't. I capitalized the THE because as I started to understand this, I realized that while there may be malocclusions from extra teeth or congenitally missing teeth or prematurely lost teeth, that soft tissue dysfunction really plays a role in almost every case of malocclusion. And that's not the way I was taught, really. We were always taught that malocclusion was multifactorial and that it was likely a result of the things that we inherit from mom and dad, or a combination, and so forth. At least that's the way I had explained it to my patients when they would ask me why their kids had crooked teeth. But to say that there was something that the body or the person was doing that might be causing malocclusion was something that I just could not accept until I started looking a little further. And in time, as I learned more, I came up with this idea that there is there's something different going on in human health and modern human history that we have not really been paying attention to in orthodontics and need to. So we call this hypothesis medically indicated orthodontic care. And it starts off like this: the human face and body are changing. We know this from the anthropologists, that starting more maybe 400 or 500 years ago, probably from the time that we started refining sugar to the time that we started producing food industrially, to the time that we started adding non-food items to our food, such as colorants and preservatives and antibiotics and fertilizers and pesticides and all that kind of stuff that's been entering our food system, particularly lately, to the time that we started using high amounts of high fructose corn syrup, among many other cultural changes that have been happening, that our face is changing. And in particular, we're subject to change in the midface. And that is because the maxillary bone, which is an intramembranous bone, is very sensitive to the input from that it gets in its environment. We call that the functional matrix hypothesis, and it suggests that when the input into the bone is not correct, that the bone does not grow in the same way that it should if the input was correct. That is, the maxilla is collapsing in 3 dimensions of space. Many people realize that there are narrow maxillas, but I think that's a limited view. We have to look at this concept that the maxilla changes shape, not only transversely, but sagittally and vertically. And that this particular phenomenon is very, very common in almost every angle classification of malocclusion. In fact, the angle classification is becoming inadequate to describe this overarching change in the human face. Instead, we're calling it craniofacial dystrophy as an overall view of what's happening to the human face. One aspect of this that's so important is that when the midface does not grow well and the mandible is being hampered in its growth, that the small jaws also mean that the breathing space from the tip of the nose to the bottom of the throat is hampered. It's just not as wide and patent as it should be, and narrow spots in the jaws create turbulence. Turbulence, as we shall see, is something that literally makes it harder to breathe. And because breathing is imperative, whenever breathing is difficult, even in the slightest bit, we have to compensate to make breathing easier. And when we compensate for anything that we're no longer competent to do, we solve a problem, but we also have unintended consequences. And these unintended consequences we're going to be calling airway-centered disorders today. Unfortunately, the way I was taught orthodontics, which is to focus on the teeth, the occlusion, the function of the teeth and so forth, it largely ignores this thesis. And even more unfortunately, the orthodontic powers that be are stiff-arming this idea because they, in essence, don't want to be responsible for the implications. However, there is a way of looking at orthodontics and working with this primal function of breathing to improve overall health and to overcome some of the medical indications that children and adults are suffering with good orthodontic care. And the good news is we do have the clinical applications of protocols available to us now to deal with these problems for kids. So I am going to give you a little bit of an overview of what these airway-centered disorders are, and maybe have you be able to see them in practice. We're not going to get into treatment today. I'm barely going to show you any slides about teeth, since the teeth really are just innocent bystanders in this game of trying to breathe well. So the airway-centered disorders include nasal or airway obstruction or congestion, limiting function of oral tissues by tethers that occur in the fascia, tongue tie being the most common. Open mouth posture, which is a deviation of oral and facial posture that has unintended consequences that include craniofacial dystrophy. We're going to look at soft tissue dysfunctions, and that is not only active functions, but functions at rest as well, and how they change input into the growing jawbones. We're going to talk about breathing deviations. This picture shows hyperventilation, but there are many habits around breathing that have gone awry for us. Sleep is an issue, but sleep is not the issue. It's the way we breathe while we sleep that is the focus of our attention. Dentistry has long talked about parafunction and clenching and grinding and so forth, but I'm going to give you a little bit of a new view of how parafunctions function. Other habits that include not only thumb sucking, but any habit that changes oral function. TM and facial pain have long been a nuisance to orthodontists. Some of us have added services for facial pain and dysfunction, into our practices. But the solutions to facial pain have often eluded us and created quite a bit of confusion over the years. One thing that I was not taught in orthodontics is that the teeth that I was straightening are actually attached to a human body. In fact, to this day, to become a board certified orthodontist, you no longer have to really show that the teeth that you've so obsessively and perfectly straightened match the rest of the body. And yet the body, the teeth and the mouth are certainly connected from head to toe, and that becomes relevant. And then finally, the fact that people will grow up with crooked teeth is not really the problem. The crooked teeth are just a symptom of an imbalance in the rest of the body. So we're just going to take a brief look at these and create this concept of all of these disorders being related to the airway. So I start by showing my my air conditioning guy at my house, holding up the new filter and then the one that I keep forgetting to change, and looking and showing me the difference between what's in the air and what we should be, capturing with our air conditioning filters. Well, the same thing is true of our bodies, because we have a perfect filter in our breathing system, and that's the nose. The nose filters the air of all the dander, the dust, the particles, the pollen, that are in the air. It warms the air to body temperature. It moisturizes. It disinfects it with nitric oxide coming out of the sinuses, so that by the time the air gets through the back of our nose, it should be relatively clean and ready to breathe. But when the nose is not able to do that filtering, there are all kinds of problems that result. Functional breathing, and thank you to my colleague Roger Price for these slides. My functional breathing should be done in an easy, efficient manner. Usually, adults should be breathing at about 8 to 10 breaths per minute at rest. I say at rest because there's no extreme demands for oxygen at the moment. That we should be breathing in about 4 or 5 liters of air per minute. That minute volume, as we're going to see, has changed quite a bit over the years. We should be breathing in and out through the nose. I know there's some breathing exercises that encourage breathing in through the nose and out through the mouth. But breathing in through and out through the nose not only filters there and makes it clean, but it helps us regulate the storage of carbon dioxide, not just in the lungs, as it's pictured here, but in our entire blood system. As you might know, carbon dioxide is the immediate controller of pH in the blood. And pH in the blood is what not only helps oxygen jump onto hemoglobin in the red blood cell at the site of the lungs, but that slight change in pH is what helps oxygen jump off of hemoglobin and be delivered to target tissues, be they muscle or organ or skin or brain, which is the highest user of oxygen in our body. There's no system in our body that's exempt for the need from oxygen moment to moment to moment. That breathing is driven by the diaphragm, that muscle sitting under the lungs, which acts similarly to a bellows. You don't have to breathe hard. You don't have to breathe deep. When the diaphragm contracts properly, the lungs immediately fill up with air from top to bottom. Breathing should be silent. There should be no noise. And of course, snoring is the thing that comes to mind the most. But anytime you can even hear the air passing through your nose or throat, that's the sound of turbulence, the sound of air swirling around, and is an indication that there's something going on that's going to limit easy breathing. When you breathe properly, you have a good balance of oxygen and carbon dioxide in the body. Now, oxygen saturation in the blood usually hovers around 96% or so, and rarely is a problem unless you stopped breathing for a long time. There's so much oxygen in the air, in the atmosphere, compared to what our bodies need, that we only use a percentage of what we breathe. That's why we can do CPR, as a matter of fact. But it's the balance of carbon dioxide that really controls the biochemistry of breathing, as I mentioned. And the deviations of that level can be a consequence. Oxygen, because it's needed by every system of the body, is relevant in the way that it's delivered. And we're going to call this functional and balanced breathing. Now, many times when you talk to physicians about this issue, and maybe even dentists, they'll immediately default to thinking about pathologies of breathing. The pulmonologist will immediately go to things like COPD or other issues where there's a severe degradation of tissue in the lungs. But what we need to focus on now is optimal breathing, and that is the highest possible functioning of breathing so that we can deliver oxygen optimally to our body. Well, that's really not the case so much anymore. In fact, studies over the long term have shown that while humans used to breathe at a rate of 4 or 5 or 6 liters per minute, that in the 1980s, well, from the 50s and onward, that there's been a significant increase in minute volume. And this increase actually parallels the onslaught of the chronic non-communicable diseases of civilization that we are also suffering at this time. In breathing volume in the textbooks shows that we should be about 6 liters per minute. But in many of these chronic non-communicable diseases, that rate has doubled. In heart disease, it's well over doubled. In asthma, for instance, it's doubled from where it should be. And in sleep apnea, it's doubled from where it should be. Why are we breathing so fast to accommodate our needs? That is, our body is literally screaming for more oxygen because it's struggling to handle the metabolism needed to deal with many of the things that are happening in this modern environment. In other words, when we have so much work to do to eliminate toxins, to deal with elements in our food that can't be digested, that either have to be stored or sequestered or destroyed or eliminated, our body's metabolism is literally doubling in amount. That's a tremendous amount of work. And it requires us to breathe heavier and faster. And as we do, we tend to blow off more carbon dioxide than we should. That is, this tendency towards hyperventilation is lowering our CO2 scores. We look at this as a relationship to the end tidal CO2, that is, at the end of the breath, the amount of CO2, which is depicted in this graph, is equivalent to what the CO2 levels are in the blood, and therefore relating to dissociation of oxygen and the delivery of oxygen to the body. So what is the problem here? How are we having such trouble breathing? In engineering, we talk about laminar flow, that is air flowing through a tube in as smooth a fashion as possible. But if there is any narrowing or limitation in an airway or in a tube, the air starts to swirl. And that swirling creates a negative pressure, and the negative pressure pulls on the side walls of the tube. Now, of course, if this is the side walls of your throat or your nose, then any tissues that are friable enough or loose enough, they will be pulled as well. And the amount of pressure that is needed to collapse the side walls of the airway, also known as the critical pressure, may change and be different for different individuals, depending on lots of factors. What causes airflow restriction? There are three factors that we talk about: structure, function, and behavior. By structure, we're talking about the anatomy of the airway. That is the size and shape and contours of the airway. When there are any narrowing spots, for instance, around swollen adenoids or tonsils, or perhaps in the nose where nasal cartilages can be collapsed, or turbinates be more swollen than they should be. These narrow places create that turbulence that pulls on the airway. By function, we're talking about physiology, and that is the stability of the airway. So tissues that are swollen or edematous or inflamed or infected, they lose their stability. Tissues that have been traumatized by turbulence over the years, for instance, someone who's been snoring for years and years on end, that creates a lack of stability. There are many areas where the airway can collapse between the nose and the bottom of the throat. And lack of stability means that even lesser amounts of turbulence are going to create problems. But perhaps most important is behavior. And I say most important because this tends to be the thing that most dentists and orthodontists ignore. And it's simply because breathing is the most important thing we do moment to moment. And perhaps the thing that is so common in our physiology that we overlook it, that we have been missing the idea that the way we breathe is a critical part of this puzzle. And frankly, breathing itself is a behavior as well as an automatic or autonomic function. So let's go down this list of airway-centered disorders pretty quickly and just take a look at them. We know that nasal obstruction can be caused by lots of different things: enlarged tonsils, nasal constriction, the deviated septum in the middle of the nose, the swollen or enlarged turbinates, cysts and polyps, tumors, even mucus it can create problems when not properly cleaned. And then allergic rhinitis, for whatever reason, these create that kind of obstruction that's going to impair function, and that leads to either blockage of the eustachian tubes or mouth breathing or lowered tongue posture, the mandible with lowered and retruded posture and forward head and shoulder posture. And these have all kinds of knockoff effects, including the things that we face in orthodontics every day: the constricted maxilla, the high vaulted palate, the malocclusion with all the different types of angle classifications and so forth. And so all of these become risk factors for the way we breathe. And frankly, the way we breathe during the day and at night when we try to breathe, we're more susceptible to these problems. And this is why people think it's a sleep problem. We've been calling it sleep breathing disorders. Really, they're breathing related sleep disorders because it's our breathing that affects our sleep. Looking at tongue form and fascial aberrations in the mouth that limit the movement of tissues. We talk about tongue tie quite a bit because we need the tongue to rest up on the palate as a scaffold for the growing maxilla. But when it does, the bone will tend to grow better. When it can't, the bone will collapse, as I say, in 3 dimensions of space. Without going into more detail about it, there is an association between a short lingual frenum and sleep related problems. This is one of many, many papers from one of the patriarchs of sleep medicine, Christian Guilleminault, and we have a lot to learn from his writings, even now after his passing. Open mouth posture is critical because, as I say, that low tongue posture changes the way the face grows. A low tongue posture and open mouth posture may include mouth breathing, but it's not necessarily the case. You can be able to breathe through your nose, but still have low tongue posture. And the reasons for that lead to low tongue posture on the left of this slide, and certainly deserve discussions, in and of themselves, that we don't have time for today. But they all lead to this low tongue posture and the many knockoff effects of this compensation. This idea of open mouth posture being a compensation for the inability to easily breathe through the nose is a major point in this area, in this topic of airway dysfunction. That chronic hyperventilation and breathing too much and lowering your CO2 levels is hypocapnia, and the knockoff effects it has on the growth of the jaws and the eruption of the teeth, and then all these other things. Again, something we don't really have time to talk about that much. But I said myofunctional disorder, soft tissue dysfunction, was the cause of malocclusion, and this is something we need to pay attention to. It's really not hard to see soft tissue dysfunction if you know what to look for. Simply that in good function, the tongue is supposed to handle whatever we eat and drink by sequestering the food and the liquid up on the palate so that contraction of the cervical muscles can create a negative pressure and suck down the food or the liquid, accordingly. But when the tongue does not know how to do or is incapable of doing that kind of function, we have to recruit other muscles to help us do that. We use the lips, the chin, the cheeks, the neck. You may even see kids blink as they're trying to swallow and compensate for a tongue that does not know how to do that. That kind of compensation dramatically changes the functional matrix around that bone. And so you can see in these pictures, lots of deviations in the teeth, in the jaw forms, in the facial appearance, the soft tissues, and of course, the activity of the facial muscles during swallow. And this is what that means by soft tissue dysfunction is the cause of malocclusion. It has become a guiding principle for me now, that whenever I see malocclusion, I now also see the various kinds of dysfunctions that the tongue has during chewing and swallowing, yes, but also during rest and especially during breathing. So breathing itself is a behavior, and chronic hyperventilation, that is breathing more than the minute volume needed to supply our bodies with adequate oxygen, are habits that are created that lead to hypocapnia, and now our biochemistry has changed entirely. This is the urgency of taking the next breath. So there are a wide variety of things that are happening in our body. This slide only showing a few of the common ones that occur from hyperventilation and hypocapnia and poor delivery of oxygen. Things like anxiety and asthma and cardiovascular problems. These are all associated with poor breathing. And unfortunately, our medical system and even our dental system is so segmented into the silos of specialties that we don't really see how oxygen and its delivery can be related to every system pathology that we have in the body. So this idea of breathing at night not being sleep disordered breathing, but being breathing disordered sleep is really important. Yes, we're paying attention in dentistry to try to open the airway with mandibular advancement appliances. Medicine is still kind of limited to the CPAP regimen. It's almost become an industry in itself where you can make a diagnosis and write a prescription and then be on to the next patient without really thinking about why this person is having problems breathing while they sleep. Extreme kinds of treatments like maxillary mandibular advancement surgery may be very good at solving the problem, but not many people can avail themselves of it. And it's not really obstructive sleep apnea that's the big problem anyway. OSA is really the end stage disease of a lifetime where the airway has been beaten up and neural reflexes tamped down because of the trauma of poor breathing year after year after year after year. That it's the breathing during the day that we need to pay attention to. And when we do, many of these upper airway problems can resolve. This really was sent home to us in a few years ago when research was showing that even when children would be snoring early in age, that they would, and if it stopped early in age, maybe they were snoring in the first 6 months of their lives, in the first year or two, that there would be knockoff effects in behavior that would be significant, even by the time they were in first grade. So the idea that bad breathing needs help as soon as it's discovered became a critical part of what we were thinking. That kids were suffering from damage to cognitive function that extended well beyond what they were born with. There are physicians that are saying there's really no such thing as ADHD, or at least not most of what we're seeing. It's because the kids are not getting good sleep, and yet kids are being medicated for these at a very early age. We know that the research shows that brain damage from poor breathing during day and night does happen quite critically for children as well as adults that are not breathing well. And when you've had at least 3 months of breathing like this, you not only have a physiologic problem, but now you start having the knockoff psychological problems because the brain is not growing as healthy as it should. And for those who say that it just will go away, that the tonsils will shrink, that the adenoids will no longer block the nose, that the jaws will grow by themselves, it's a myth. That these problems do not go away, and their knockoff effects can last a lifetime. Now, speaking of lifetime, We're looking at another Guilleminault paper looking at 7 kids that had SIDS, sudden infant death syndrome, and horribly, there were certain things that they had in common. One is that they all had chronic indicators of abnormal sleep. They all had enlargement of upper airway soft tissues. They all had a narrow, small nasomaxillary complex. And fortunately, most kids do not die of this, but many kids, and certainly every kid with malocclusion, has some risk factor for having this. Well, dentistry can see things later in years. We talk about bruxism and parafunctions, but it's important to realize that the body picks parafunctions to solve a problem. Clenching and grinding is solving a problem. Opening the mouth is solving a problem. And so as dentists, we have to start becoming Sherlock Holmes for these cases to figure out what problem they're trying to solve. And then in the form and function spiral, what are the knockoff effects of it? A lot of orthodontists will hide behind this idea that, oh, well, this is a chicken and egg problem, and we don't know which one came first, the chicken or the egg. Maybe that's fine for entertaining young children, but as adults, we know it's not chicken or egg at all. It's chicken and egg. If you want an egg, you need a chicken. If you want a chicken, you need an egg. It's not form or function. It's form and function. And form and function can be going in a spiral, either leading to better health or to ill health. And unfortunately, when you see kids with bad sleep or crooked teeth for that matter, they're going towards ill health. Crooked teeth are not just they're not just something somebody has. It's something somebody is developing, had developed, is developing, will develop unless we do something about the underlying causes. So look at some of these parafunctions: clenching, bruxism, tongue posturing, forward head, open mouth posturing, finger habits. All of these, they are solving a problem for the body. What problem? They all open the airway. Isn't that interesting? Now, this topic of TM disorders, we could do a whole day on this, and many of you probably have adopted services in your practice to help with this. But I'm just going to briefly say that many of the gurus of TMJ have focused on trauma as the cause of TMJ dysfunction, that they're always looking for that one incident of falling on the chin against the coffee table at 2 years old, or off the bike at 6 years old, and or the motor vehicle accident, and aha, there it is. That's the reason for your TMJ dysfunction, without really proving it. But there is a trauma that happens to the TM joint that has nothing to do with that. It has to do with a micro trauma from soft tissue dysfunction. So very briefly, things like tongue thrust create a distalization of the mandible and a constant compression of the joint, the hundreds or thousands of times we swallow every day. The ring of muscles from the lips, the chin, the cheeks, and the pharyngeal constrictors, they all become recruited in swallowing patterns when the tongue doesn't know what to do, and constantly pull on the lower third of the face like this huge rubber band that surrounds the bones. The tongue in between teeth posture takes away the stabilizing effect of centrifugation and allows compression of the joint. Forward head posture, which is adopted to keep the airway open, will have all kinds of knockoff effects on the masticatory and the cervical muscles, and change the way the bones grow. Snoring with the mouth open hinges the mandible. You have to watch somebody snore, not just listen to them. Watch the mandibular motions that they go through and understand that that mandible is constantly being forced up into the joint. And then restriction of mandibular movement from the collapsing maxilla above changes the way the mandible will grow. And this is why the angle classification is no longer satisfactory to describe an orthodontic diagnosis, even though that is the pillar in orthodontic, in my orthodontic education. So the idea that the teeth are attached to the rest of the body is something new for us orthodontists, certainly. And we have to look at how the posture of the head being held up against gravity alters the cervical spine, the thoracic spine, all the way down, literally to the feet. And looking at a patient's posture is really critical. And then finally, malocclusion is no, as I say, no longer the problem, it is a symptom. In fact, it is said that malocclusion is the body's solution to a problem of equilibrium and homeostasis. In fact, this is why when you straighten teeth without looking at what that equilibrium problem is in the rest of the body, that you have to hold the teeth straight forever. Orthodontists have just accepted as natural the fact that we have to glue the teeth together to keep them straight. And yet we call the teeth stable. Nothing could be further than the truth. And everybody knows that when you stop wearing your retainers, the teeth are going to shift again. Malocclusion is stable. When you have a malocclusion, that's there because the body wants it that way, essentially, to neutralize the balance of forces. And that unless you take care of the dysfunction that underlies this problem, then you'll never really have stability of the teeth. So thank you to Dave Singh for that quote. So I want you to start looking at your patients, put their head back and look up into their palate. If it looks like somebody took a thumb and pushed it into a ball of clay, that's called the high arched palate, the Olgaval palate, the keyhole palate, the thumbprint palate. I don't care what you call it, but it's happening because the balance of forces is incorrect because the tongue is not sitting up on the roof of the mouth. And it's not just the vault, it's that tissue around the whole perimeter of the maxilla that's at fault. That is all collapsing inward. And you can see it at 3 years of age, you can see it at 7 and at 8 and 10, but you can also see it at 42 years of age. You do not outgrow this. And what's most important to understand is that this is a deformity of growth. It's not what somebody has. It's what somebody developed. They're developing it when they're sitting in your chair, and unless you do something about the soft tissue dysfunction that created it, it will keep going. So in summary, chronic nasopharyngeal obstruction, tongue form aberrations, open mouth posture, myofunctional disorders, chronic hyperventilation, breathing disordered sleep, bruxism and power functions, TMD and facial components, cranial and postural issues, and malocclusion. If you see somebody with crooked teeth, you need to start looking at these other things as well. Check somebody, just ask somebody to hold their lips together for 2 minutes and watch how well they can do. Have them lift the tongue, lift the lips and the cheeks, and look for tight frenum attachments. Watch them while they are sitting in your waiting room or in your chair, and look for open mouth posture at rest. When you see that, the tongue is not on the palate. Watch for myofunctional disorders when you have somebody rinsing out. Watch them swallow. Look for movements of the face and the lips and the chin. Watch for chronic hyperventilation and hypocapnia just by counting their breaths per minute. If it's an adult and they're above 6 to 8 breaths per minute, then they are part of this social phenomenon of hyperventilation. Ask about sleep, and there are plenty of ways to do that now. Brochures and questionnaires and validated sleep questionnaires are available, and your patients should be getting them at least periodically. You can see bruxism and parafunctions. We've always been seeing it, but now just don't write it off. When patients are breaking their molars, when they're ruining your beautiful porcelain work that you just put in 3 years ago, and they're wondering why it didn't last, you have to start looking at the fact that these parafunctions are solving a problem. And then when you have TMJ and facial pain components, don't assume that it was just a childhood accident or a motor vehicle accident. Start understanding the idea that soft tissue dysfunction batters the TMJ components. Look for postural issues. And then, as I say, when you see malocclusion, that's a hint that all or any of those things were there. One last word is that the American Dental Association has adopted a statement some years ago already that defined the role of dentistry in the treatment of these sleep-related breathing disorders, and has essentially said that as dentists, we are not allowed to diagnose and treat sleep apnea. And I agree with that wholeheartedly. You don't want to be messing around with someone that may have cardiovascular complications from years of obstructive sleep apnea, because it's impending doom. And you don't want that to be on your head. Yes, the physician may ask you to make a mandibular advancement appliance, that's fine. But this statement goes beyond that. It has a statement in about children that I think is the most prescient thing that I've ever heard come out of the ADA. Love them as I do, card-carrying member as I am. And it says, in children, screening through history and clinical examination, which we must do. In fact, I'm on the task force for the ADA that is now doing clinical studies of a screening routine that we will someday propagate throughout the profession. Identify signs and symptoms of deficient growth and development, because this really is where it's coming from. And not everybody's the same. There are all kinds of differences, but we have to pay attention to them and all those other risk factors for airway issues. If the risk for sleep-related breathing disorder is determined, intervention through medical dental referral or evidence-based treatment, and we are gathering the evidence as institutions will permit, may be appropriate to help treat these problems, and this is where I think we really need to pay attention, we have to help children develop an optimal physiologic airway and breathing pattern. We have to make sure their anatomy is correct, their physiology is correct, and their breathing behaviors are correct. Unfortunately, there is nobody else in medicine that's doing this, that's teaching this. I have, as an orthodontist, I have to teach a child to clean and clear their nose. I have to teach a child to close their lips and put their tongue up on the roof of the mouth. I, as an orthodontist, and often with the help of other allied health professionals, have to teach people how to swallow properly and then get a good night's sleep. We have to teach people how to have an optimal airway and breathe optimally through it. Thank you very much. Did I do okay on time there?
Well, you went a little long, but that's okay because it was a fascinating lecture, lots of incredibly good information. And for someone like me that doesn't have a strong background in this area, I found this to be incredibly useful and incredibly valuable. We have, we're out of time, but I'll try to take a couple of questions. I did have an interesting question. There's been in the past 3 years, we've had our kids wearing masks so much of the time.
Hmm.
Are there any consequences to children wearing masks?
I actually think it can be helpful. Many kids, most of the kids that walk into my office are hypocapnic. That is, their CO2 levels are low. And one of the best ways to restore that, and we test it, by breathing into a bag. This is why when people are lightheaded, they're told to breathe into a bag. For fainting and so forth, the fainting and lightheadedness, it's a lack of oxygen, usually from some kind of a hyperventilation fit.
So I
But
mean, these kids are like chronically hyperventilating.
chronically, and the body adapts to it because we have to keep breathing no matter what. And there's a slow a slow slide down in native CO2 levels that affects the way oxygen is delivered. It can
Interesting.
explain many of the unintended consequences.
Interesting. You mentioned how tonsils and adenoid swelling can be part of that soft tissue that causes this whole issue. I mean, have the recommendations from physicians changed on tonsil and adenoid removal? It seems like it's done less frequently now than it was years ago. What are
Yeah.
your thoughts?
Well, the American Academy of Pediatrics actually came out with a statement, maybe 5 or 7 years ago, that suggested that in cases of sleep apnea, that's frank sleep apnea, that TNA should be considered as a frontline treatment if more conservative methods don't work. They didn't print it in the statement, but behind the scenes, they suggest that palatal expansion is sort of this growing, recognition is growing that this can be a helpful thing. But even palatal expansion is a little bit limited because it doesn't really address the behaviors that cause the problem in the first place. Tonsils and adenoids don't have to be so swollen that they're blocking up the airway. They get irritated by unfiltered air through mouth breathing, for instance.
Right, but of course, but because you got your tonsils and adenoids swollen, you're breathing through your mouth, which in turn, inflames them more.
That's
Yeah.
right. That's the negative form and function spiral that I talked about, and you have to break the spiral somewhere. And
Amazing.
You can do it anatomically, you can do it physiologically, maybe with medications. You can do it behaviorally by teaching a child to clean and clear their nose, keep their lips together, and then the swelling can reduce. That is, as long as it hasn't been, present for years and all scarified and all that. But certainly in 3 and 4-year-olds, to just default to taking out tonsils and adenoids, I think is a little bit misguided.
Very good. Your comment that malocclusion is stable, and that's why if you haven't changed some of these soft tissue patterns, that post-orthodontics is going to be unstable.
Yeah.
I found that to be a really interesting way to look, because we've got a lot of questions about, and you went into it later on, that, hey, orthodontics is going to be unstable,
Yeah.
if you haven't dealt with these other causes.
It is. It's kind of a myth that we've told ourselves, because in principles of occlusion, you want anterior guidance and you don't want traumatizing contacts and all that. But if you don't take care of, say, the underlying breathing problem and still have parafunction, it doesn't really matter how much anterior guidance you have, you're still going to destroy the teeth eventually.
Right. Well, Barry, thank you so much for a fantastic lecture. There's a lot of questions here about people wanting to know more. I can say that Barry will be speaking at our symposium, our sleep symposium, which I believe is in May or June, and he'll be
April
on the main
21st
podium.
and 22nd.
Thank you.
You're
And
welcome.
then he will also be doing a workshop on the second day. I would say this is something that we in dentistry have to become much more aware of. And it is, as he showed you, it affects all areas of restorative dentistry as well. So thank you, Dr. Barry Raphael.
You're welcome.
Thank you to our panel. And thanks to all of you for joining us today. And we're going to be off next week because we have our Glidewell Implant Surgical Symposium. But then back on March 31st, we're going to have a special 3-year anniversary edition of this online study club. And we're going to have some special guests. We're going to have Jim Glidewell, Stephanie Goddard. We're going to have Chuck Cohen from Benco to talk about the future of private practice, what successful dentists need to know. So you do not want to miss that. So we'll see you back here in 2 weeks, same time. And Barry, you take care, and all folks have a great weekend, a great week, and I'll see you in 2 weeks. Take care, everybody. Bye-bye.